Hi, nice to be here. Thank you very much all for inviting me to another talk in Chile. That's been many years that I've been coming there and also being part of this very prestigious presentation with all these wonderful other speakers and friends. I take the liberty of changing the topic a bit, and it will be called The Changing Face of Complicated Pneumonia in the Era of Pneumococcal Conjugated Vaccine. It's not going to be surprising for you that pneumonia, or what I prefer to actually call lower respiratory infection, is a highly prevalent entity in childhood, the largest single cause of mortality and morbidity around the children in the world less than 5 years of age. And statistics from the Western world, our world, where I function, suggest an annual incidence of 3 to 4% of the pediatric population below age 5, substantially higher number than in adults. It is important to acknowledge that the review today may not be reflective of large, lower and middle income parts of the world. And so I need to bring about a caveat about too many conclusions. I also would like to point out that much of what I'm covering is very carefully covered in this recent review in the Lancet, Complicated Pneumonia in Children. And you see that many of the authors here who come from 5 continents actually are participants in this very meeting. Complicated pneumonia is associated with a whole list of problems that are on this list that comes from Bradley's papers in 2011. But I will be trying to cover today pleural effusions and empyema, bronchopleural fistula, lung abscess, and necrotizing pneumonia to different levels of intensity based on what I think are the important pieces of information to share with you. And I'll start with the most common issue, which is pleural effusion in children, and would like to start by defining that empyema literally means purulent appearing, or it looks like pus. Now, we use it loosely as a predictor of complicated outcome because it doesn't really have a very specific definition. The diagnosis nowadays should be done by ultrasound, and ultrasound is nowadays available at the bedside. And this is an example of a diagnosis that is being made by ultrasound. Importantly, what you can see here is that there is an anechoic fluid that is an uncomplicated pleural effusion, while you can see the echoic fluid here that is the complicated version. And what you see here is the septae, the fibrinoid process that causes the complications that I'll show you in a minute. And there is not a better tool in our hands at this point in time to make a diagnosis. And I think it makes a difference when you know one from the other. The old teaching, particularly in adults, has been that in this paper that the sun should never set on a parapneumonic effusion. The only point that I think is important here is that timing is crucial, and I'll elaborate on that a bit. This comes, however, from an old paper in '89 by Richard Light and company. He is the guru of pleural effusions. And I don't think that this is truly relevant nowadays to our practices in pediatrics. I would like to also introduce the concept of video-assisted oracoscopic surgery, or VATS. I hope that most of you have it available to you when you need it. What you can see here is that instead of the thoracotomy, we are actually able to punch a few holes in the lung, introduce instrumentation for visualization, and tools for instrumentation that would include sampling the pleural space, but also taking biopsies from the lung itself. Very important tool nowadays with varying degrees of treatments. So now when we talk about pleural effusions, they are frequently the complicated elements of childhood pneumonia. And opinions regarding diagnosis and treatment vary very substantially. And I will just outline here four of the approaches that one may take. And I'm not going to recommend one over the other, just refer to you information about where you can go to make this kind of decision. So interestingly, I think that the most prevalent approach nowadays is to use antibiotic therapy and delay pleural tap either for diagnosis or for treatment until the child declares himself or herself as responding or not responding to antibiotic therapy. The reference for this is a post studies from Paris from 2006, an excellent study that is controlled, and Carter's study from 2010, both reaching the same conclusion that instrumentation and aggressive approach is not absolutely necessary. However, there are other approaches that are more aggressive. One of them is a thrombolysis after the placement of a pigtail drain, which is a smaller drain that can be done without the help of a surgeon. The best papers regarding the information about that comes from Anne Thompson from Oxford in 2001, and more recently for Ian Balfour-Lynn from 2005. Early video-assisted oracoscopy or VATS has been very prevalent in the early 2000s. Much of the literature has been written by surgeons, and a very good paper by Schultz from 2004 is advocating this approach that, as I mentioned before, is not necessarily the updated approach. Repeated ultrasonographic guided needle thoracentesis without actually placement of a tube comes from Dr. David Shoseo from 2002, and I have found very little support by others doing this. The thing that I would like, however, to highlight is that there is a matter of timing when you make your decisions. So when you start with a pleural effusion or a parapneumonic effusion, you have an exudative phase that is free-flowing fluid with low cellularity. And if you wait long enough and it turns out to actually be an empyema that is going to fibrose, you are going to get to the organizing phase where there is fibroblastic activity, peel formation that eventually leads to a gelatinous fluid accumulating in the pleural space, which is too late then to put a chest drain because it's not going to work. In between the two is your window of opportunity, which is a fibropurulent phase, which is fibrin accumulation, abundant pulmonary polymorphonuclears, and loculation that starts to occur with a fibrinosis, with a fibrin activity. And the window between these two typically is 48 to 72 hours. Once you are delayed beyond that, you may be getting to the organized phase where you don't have much to do. This is the organizing phase. This is the fibrin process. What you can see here is that you see strands of fibrin organizing here, causing these compartments that you have seen on the ultrasound. And once you have this loculation or compartmentalization, putting in a needle or a drain is not helping you very much. If you have early enough time and they are not very thick and not peel, then you can use thrombolysis and the drain may work, but otherwise you need to go to a surgery. And this is a VATS, what you see here. The lung is collapsed here. The surgeon goes in and cleans all this stuff until they get the pink of the lung and the pink of the chest wall. And that's the end of the procedure. And that's where you have cleared whatever accumulation has occurred in the space. This is another example of a loculation. You're sitting in one loculation and you have a window to the next one. This, of course, is artificial because you have a collapsed lung with the VATS, and otherwise they may not look exactly what I'm showing you, but this is the idea. Now, what are the predictors of a complicated outcome of an empyema? Well, the hierarchy that emerges from the literature as to the relative efficacy of individual pleural fluid parameters to predict complicated outcome for pleural effusion is pH. So if you have a low pH and acidic pH relative to the alkaline pH that is normal, or a low glucose, these are the best predictors of a complicated outcome, and LDH and cell count that are commonly used are less good. And if you want the evidence for that, there is a paper by Mitri, which we have written from Boston on a series of kits from 2002. There are many people who advocate not to do any analysis on pleural effusion, but we feel strongly that there is information there that should be used. And the question is, when you compare thrombolysis to VATS, is there an advantage of one over the other? There are now a number of comparative studies that do one or the other. This is a randomized study coming from Great Ormond Street by Dr. Sonapa, comparing VATS to urokinase. So it's one or the other without a pre-decision about doing one or the other. And the results of this study, as are 3 others or 4 others at this point in time, is that they are comparable. And when you look at the time in the hospital, VATS is 6 days, urokinase is also 6 days, and there really is not much of a difference between the 2 approaches. As far as what we recommend in our paper, this is the De Benedictis paper, the review paper in the Lancet. I'm not going to go into details, but I think it offers an algorithm of how you may want to think about whether you need to act on a parapleural, on a parapneumonic effusion or not. And this is one, but not necessarily the uniform or unique one. Let me go to the bulk of my talk, which is going to be focused on my favorite topic, which is necrotizing pneumonia. So necrotizing or cavitatory pneumonia, which in the adult literature is also called massive pulmonary gangrene, has been known for a long time in the adults and was supposed to be something that would require a resection of the lung. Here is an example of one such lung that has been resected in an adult. However, the information about this occurring also in children started to emerge in 1994 with this memorable paper from Eitan Kerem from Jerusalem and Dr. Baziv, who was a radiologist, and they used CT scans. And this was the first use reported for CT scans. This is 4 cases with necrotizing pneumonia in childhood in children who were admitted for bacteremic pneumococcal pneumonia. Ages were 1 to 7.5. And what they showed is that there is in the CT scan a liquefaction of the lung that can only be seen by CT scan. The complicated course of fever lasting up to 20 days, very prolonged hospitalization. This would compare to a regular pneumonia where you typically don't need to keep the child in the hospital, but if you do, they should respond within 2 to 3 days. And in contrast to adults, complete recovery was noted and no invasive investigation such as a biopsy or resection of the lung was used, and the recovery of the children were remarkable. So let me just present to you the most difficult case that I have probably treated, and this is not going to be a recommendation that you follow this, but it's going to give you a sense of the natural history that I have not seen reported in any other place. This is a 3-year, 9-month-old child who has been very, very sick and was taken to the emergency room only when she would not go down from the bed. She did not get antibiotics because the family thought she had an upper respiratory infection. This was the admission chest X-ray, and what you can see here is a complete white out on the right. That typically means that you have a pleural effusion, but this was not detected by the ultrasonographer who did that, so there has never been a tapping in the early stages of this disease, and so we don't really know the organism. The organism was never defined. However, it was assumed to be strep pneumonia or Staph aureus, and she was started on Augmentin. And I would like to take you through the weeks and months of what happened next in this case, because I think that we have a radiographic presentation that is very typical. So what you see here on day 4 is that you see grayness here, and that typically would mean that this is a good news because this is recovery. However, the child was disproportionately sick. So we got a CT scan. This is a classical CT scan of a necrotizing pneumonia. And what I would like is to take you through this. This outside is the pleural effusion, and you see that is uniformly gray. It's actually loculated, but you don't see this on a CT scan. This is the inside of the lung. So this is the lung. This is the typical pneumonia or atelectasis. This is the infiltrate, solid white. But you see outside of this, within the lung, here is the pleural line, you see that there is liquefaction of the lung. And the reason that we call it liquefaction is that this gray is probably closer to the gray, to the fluid outside of the lung, to the consolidation inside of the lung. Importantly, these cases need to be done with contrast, because sometimes if you don't have the pleural line with the contrast, you won't be able to tell the inside from the outside of the lung. And you can see it on this window that it's very difficult to know the liquefaction in the lung with the liquid from outside of the lung. This is day 6, only 2 days later, and the child is continuing to be very, very sick. And what you can see is that the CT scan 2 days later, and again, this is not a recommendation to do this, but we did not understand the disease at that point in time and could not understand what is happening. What you see is that what used to be pleural, liquefaction, is now cavitation. So there's liquefaction and cavitation side by side. Only 2 days later, this is a very, very rapid process. And what you see here is this, you see a very large irregular pneumatocele. Day 9, which is a few days later, so 3 days later, you see that there is a large pneumothorax. This is probably a pneumothorax ex vacuo, probably indicating that there is a bronchopleural fistula, that the cavitating lung is now communicating with the pleural space. There is no tension pneumothorax, but there's certainly leakage from it, and a chest drain is absolutely necessary. This is day 9. Again, what you see here is that the recognition of what is inside and what is outside of the lung becomes very, very blurred. You can see the pneumothorax, and you can see the pleural, the pneumonia here. Another week later, child is still very sick. You can see a complete destruction of the lung. The pneumothorax is replacing much of that, some fluid. And this is the beginning of the recovery of the lung, which is good news. And at this point in time, the child started to be well, but the bronchopleural fistula was still draining. May 9, this is 4 months later. And this is very good news, because the child has been discharged, went home. And what you can see is that compared to previous x-rays, this is an example of day 9, and that's 4 months later, the lung is essentially completely recovered. And we did a CT scan in September, which is 9 months later, and you can see that the recovery is essentially complete, with no resection of the lung, with not much intervention with the exception of the lung drainage. And so the prognosis appears to be very good, and that seems to be the case in most of the cases. So this is September. In September compared to January, you can see the level of recovery, which again is the good news in the predominant cases that we are seeing or have been seeing for the many years. So I would like to just give you a little information about our old experience. This is a publication from 2008 in the European Respiratory Journal. This is the largest case series of necrotizing pneumonia that has ever been published since then. Unfortunately, it's spelled with necrotizing with an S because it's a European journal. So if you look at necrotizing with a Z, you will probably not find it. So these were about 120 cases. They were selected by the radiologist. He selected 80 cases that were unequivocally necrotizing pneumonia. And those were the ones who are included here. So 80 cases going between January 1, 1990 to 2005, February. We have not identified any cases between 1990 and 1993 since they were not published yet. As you may remember, the publication from Jerusalem was in 1994. And the median age of our cases, the 80 cases, were 3.6 years, ranging from 4 months to 19 years. And I'll show you this very young patient because he was particularly interesting. About half of them were male. Take-home messages from this paper is that 96% of the patients reported an initial symptoms of high fever, 84% reported cough, 91% were seen by a doctor prior to admission. Many of them have already been on antibiotics by the time that they have been seen, so making the diagnosis difficult, as I'll show you in a minute. 53% required oxygen. Mean duration was 6 days up to 27 days with fever. So very different from a regular pneumonia, and mean length of stay was 15 days of up to almost 3 months, and these were the ones who had developed bronchopleural fistulas. Mean duration of antibiotics was 13 days, but lasted up to 3 months because there is not very much clarity about how long the duration has to be. Nowadays, I just would like to show you how the diagnosis can be helped by CT scan. There is not necessarily a need to do a CT scan, but if you do it, you see here the consolidated lung. You see here liquefaction that is either in or outside of the lung, liquefaction in or outside of the lung. The radiologist can actually help you, and here is an example why the radiologist will be able to paint for you, the blue being the effusion, the gray being the necrotic lung, and the pink being the consolidated lung. They can be actually defined and quantified by the radiologist, which is sometimes very helpful, and particularly when you get a 3D presentation of these two lungs. So this is the case that I just showed you. It shows there's absolutely no aeration in the left lung that is affected by pneumonia, necrotization, and empyema, while the right lung is quite well preserved. So the conclusion was in 2008 that we think that the necrotizing pneumonia is more common condition than appreciated. CT scan is required to establish the diagnosis with confidence, and similar to previous report, our study reveals that the clinical course is typically prolonged and often complicated. Just want to point out that the difference between lung abscess and necrotizing pneumonia should be kept in mind. The treatment may be similar, but they are not the same processes. They also look very different on an X-ray and a CT scan. What you can see here is a typical CT scan of a lung abscess and the typical CT scan of a necrotizing pneumonia. I don't have time to go into detail, but you'll pick up that they are very different. Epidemiologically, what happened during the years 1997 and 2006 is that we have started to see a lot more complicated pneumonia. This is a representation of empyema in the United States, and you see that particularly in the younger ages, there was a threefold increase in the population with empyema, and the hospitalization trends in the population during this year, 1997 to 2006, which is the time that we started to introduce the pneumovax. What you see is that the rates of community-acquired pneumonia within vaccination has gone down in the less than 1 year of age by 22%. However, there was an increase overall of complicated pneumonia in the older ages. And the 8 to 12 and 13 to 8 actually substantially went up during those years. And in more detail, when one analyzes any complications, there was an increase of 28% during those years. When we talk about local, we talk about empyema, lung abscess, or necrotizing pneumonia versus systemic, which are conditions that require hospitalization and ICU or ventilation. And what you can see is that during those years, 1997 to 2006, there was a 28% of increase of complications, starting particularly in the year 2000. The local complications, which are the lung-related, the ones that are necrotizing pneumonia or empyema, went up by about 77%. And the systemic complications, by the way, these 77% was mostly represented by empyema. And the systemic complications, meaning ICU, ventilation, and mortality, has overall gone down with the introduction of the vaccination. In more detail, any complication, age less than 1, there was a decrease in 25% in the very young. However, in all other ages, all complications went up. And when you look at systemic complications, 35% decrease in the very young and unchanged in the other groups. So there was not much of a change. But the topic that I would like to cover most importantly is local complication, which is the pleural effusions and necrotizing pneumonia and their complications. They went up in all ages across the board. So despite the fact that we were immunizing kids, there has been a marked increase in the complication rate, particularly ones related to necrotizing pneumonia and pleural effusions. This is the picture that we have detected in Boston during the years that I was there. 1990 to 93, there was none because we didn't know what to look for. And then 1993, 94, these are clusters of 2 years, and you can see that up until 2004, there is a marked increase in necrotizing pneumonia in the city of Boston. We're only one of 3 hospitals, so the numbers probably represented only a segment of the population. Similar to what we detected in Boston was across the ocean. This is Newcastle upon Tyne. This is in the UK. And these are representation of empaimas in the city. And you see that between 1997 to 2003, there was a marked increase in empaima. You see 18 cases here. And these are cavitatory pneumonia, which is another word for necrotizing pneumonia, a similar process to ours. And so what we were showing was this marked increase. And then there was quite a bit of silence in the literature about what happened later. And there was very few publications that tackled the problem of necrotizing pneumonia and empaima. And the next that I could find that actually looked at the epidemiology was in 2013, so quite a few years later. This is from the Robert Debré Hospital in Paris. This is a one-center experience showing necrotizing pneumonia between 2006 to 2007. These are the 1,000 cases of community-acquired pneumonia in the ER. Of these, about 200 were admitted, and these are the single cases of necrotizing pneumonia. So you see 6 in this cluster of 2 years, about 12 this year, 14 this year, which was the H1N1 flu. So the numbers were not dramatic, but it did not go away, but we didn't know very much about it. So when I was in Puyehue in 2005, I actually presented necrotizing pneumonia as one of the topics. And it was a novel concept and people were very interested, but the interest went away after that. And when I talked about it, I was asked, why are you still talking about it? Is that an issue? And the answer is that we didn't really have a good answer until 2017, when this review from Queensland, Australia was presented. And the topic, actually the title was Necrotizing Pneumonia, an Emerging Problem in Children. So we are talking about 4 years ago, where they thought that about 7% of complicated pneumonias were representing necrotizing pneumonia, a number that we certainly are not experiencing here, but they are relying on world literature when they come to this conclusion that I would suggest to take with a grain of salt, but it appears to still be a problem to tackle. Let me just approach the question of the microbiology in these cases. So as I may have mentioned, about 50% of the cases were unidentified. These are the organisms that we have never identified over the years in Boston. The expected and found incidence of the most common organism was 23%, and these were pneumococci that were known to be the major factor in the cause of necrotizing pneumonia. In the years after that, we have seen many more organisms, including Pseudomonas, Fusobacterium, and introduction of staphylococci, and unfortunately, MRSA in the United States, or methicillin-resistant Staph aureus, has become an important player. And this was unfortunate, exemplified by this 4-month-old who presented with MRSA. And what you can see here is the necrotizing pneumonia developing, cavitating, necrotizing pneumonia with cavitation, large cavitations forming, and the CT scan showed an essential destruction of the right lung. And these are just cuts of the CT scan that you can see that almost a disappearance of the entire lung. The good news in this child, however, as occurs most frequently, is that within a few months, the lung has fully recovered and the child has gone quite well, and on follow-up, everything was fine. So the question is, how do we identify the etiology of these cases? What we did not have during those years of the research was PCR. So molecular diagnostic tests, particularly PCR, using blood or pleural fluid would be the best tools to identify the underlying organism, even if the organism does not grow on culture. So that would be our take home in the Lancet paper, that these would be the best diagnostic modalities to use it. Importantly, one should remember what has been actually mentioned by Dr. Chang, that Mycoplasma pneumonia may actually be a cause of necrotizing pneumonia, and this has been particularly described in Asia. This is a paper from Wang from Taiwan of 5 cases of ages 3 to 14 presenting with bona fide necrotizing pneumonia, and these are cases from China showing the same with Mycoplasma pneumonia underlying it. The treatment of these cases is with a prolonged course of antibiotics. Nobody knows exactly how long. IV initially, then replacing it with orals. The initial choices should be guided by the local microbiological knowledge, and then modifications according to the results, the clinical results, and hopefully PCR or culture results that will dictate the course. The last piece that I would like to talk about is the pneumococcal conjugated vaccine. The 7 conjugated vaccine, or PCV7, was introduced in 1997 in the United States. And interestingly, by 2007, everybody has been essentially covered by it. But what we have been observing starting from the early 2000s is that something has changed with the complicated pneumonia. This is a paper of hospitalized kids with pneumococcal pneumonia. And the children who had uncomplicated pneumonia, for instance, had only 4% of the cases having the type 1 that was not covered by the vaccine. While the complicated pneumonia type 1 that was not covered by the vaccine was 25%. So the question that emerged is it possible that while we are vaccinating effectively, we're not covering enough? And the process that is happening now is that a pre-selection for uncovered species is coming up. And in fact, this paper from 2011 talks about the serotype replacement in disease after pneumococcal vaccination. And what it says is that there was strong evidence that colonization with non-vaccine type, or NVT, increases in vaccinated population. Non-vaccine types have increased among asymptomatic carriers in a process that is dubbed serotype replacement, and to a lesser extent, non-vaccinated type have increased as cause of invasive pneumococcal disease. In other words, the vaccination, while reducing overall pneumonias, community-acquired pneumonias, has actually caused a resurgence of the uncovered types. And this was changing now with the PCV13. In 2010, the additional 5 types were covered. So we went from PCV7 to 2010, the PCV13. And with that, we have seen a dramatic decrease of everything. So this is PCV7 types. And what you can see that from 1997, there was a marked decline of pneumonias and complicated pneumonia as of that period when that observation was made. The type that were not covered started to go down. And now in 2010, when we added the five type coverage of vaccines, we've actually flattened the curve completely. And now the only complicated pneumonias that we are seeing are the remaining uncovered vaccine types. So the remaining possibly 80 odd types that are much, much less frequent. But overall, we have seen a marked decline. And with that, this is another depiction of the same all invasive pneumococcal disease coming from the CDC. See a decline here, and these are the PCV5 that has dramatically declined after, so these are the added PCV that were added to the PCV7, constituting a PCV13, and we see essentially a flattening of the incidence of these pneumonias. The statistics from the CDC suggest 30% cases were prevented and possibly 3,000 deaths were prevented with this introduction. And so the news are good. The complicated pneumonia numbers are going down. What I did not cover is something that I would like to just mention, that the bronchopleural fistulas are a relatively common complication of the necrotizing pneumonias. We came to the conclusion that we cannot show statistically that if you do not leave the chest drain in, and chest drains are often needed because about 80% of necrotizing pneumonias will present with pleural effusion. If you leave the chest drain only for a week, the chances of developing bronchopleural fistulas is substantially reduced. So this is the last sentence, and I would like again to express my gratitude for the opportunity to share this information with you. And I think that we'll have time to questions later on.